Okay, thank you, the Professor Jia's introduction. And my topic is so long, so I will repeat again. And the content of my topic will main three topics. First, I will describe the breast cancer in Taiwan, which called a main need, the special characteristic of on the AP data. And the second, I will talk about the research we cooperate with the Taichung Veteran Hospital, which cover the new SNP from the AYA. AYA we so-called adolescent and the young adult cancer. And the third, I will talk about some efficacy difference between the chemotherapy regimen in the Asia AYA women. This is why we have the new mission to receive the NGS database from the NHS to the our NHI, and in the coming year, we will try to do the HTR, health technology reassessment. So this is a case how we do the reassessment for the traditional treatment code, okay? And we can see in Taiwan, after 20,000, there's still a very high, steadily increased age study instance. And also you can see after the 2017, the cases for the female breast cancer, they are over the 80. And in the past 5 years, this data is quite stable. It did not going up and did not going down. So in Taiwan, we're facing some steady increasing the phenomena for the breast cancer instance. And if we see the annual percent change for the breast cancer instance for AYA and the non-AYA, we know the non-AYA is still the majority cases sources in Taiwan. But however, in the past 20 years, before the 2010, the APC is around 5.7. But after the 10 years, before the 2018, the APC will decrease from 5.7 to 3.2. But right now, the past 5 years, the APC is around 0.38. It means the increase is very stable, did not showing the upward trend. But however, the AYA, the APC is for the past 25 years, they are still at 2.6. So it means the proportion for the AYA among the whole breast cancer, they are very, very, the impact is very, very increased recently. And we can see, though the USA and the UK still have the high breast cancer instance compared with the Asian country, but we can see the UK since 2019, their instance is dropped very strikingly. But in the Asia country, we compare the Taiwan, Japan, and the Korea. We can see in the 2016, Japan and the Korea, they reached the peak instance for the two countries. Taiwan showed the peak high around the later 1 year. So we have 2018, but in the 2019, Taiwan surpassed the Japan. So right now, compared with these three countries, Taiwan is the top one. But compared with the Western country, we still low. But you can see the young onset breast cancer in this area is very, very important and dominant. And we can come back to show the mortality rate. Compared with the past 15 years, the standardized mortality rate, the top 10, most of them are declining gradually. So our government is very happy. They have some policy successful, but there are still three cancers still increase. Sorry. First is the female breast cancer. This increase. Second is the prostate and the pancreatic. Prostate is the male and the pancreatic. So in the future, if we want to the high candidate should to be included in the policy screening, the prostate will be the very important and we're thinking about. And now we can see some possible and some successful biomarker have been developed. So next day we will do the very carefully efficacy research to tell the government, is it possible? Is it the right time to do the prostate cancer screening? And if you go for the global view, the UK and the USA, the breast cancer mortality is decreased steadily, and our Asian country is increased. So maybe in the later, maybe in some years later, maybe have the cross. So this is we needed to figure out this very important problem. And the second, I will talk about the GWAS study for the AYABC breast cancer compared to control. Okay. And we have the data set from around the 1,000 breast cancer patient, and then look at about 70 million SNP. And we focus on the age less than 45 years, and we have the around the 300 AYA breast cancer patient, and we're using the Taiwan Biobank data to look at the 88,000 people, and the variant we're using the 16 million SNP. And using the one case matching with the 4 control. So and we also look at the 40 million SNP and do the SNP quality control and the sample quality control. And we're using the human genome 38 edition to look at the intersex SNP around the 4 million SNP. And after that, we're using the PGS, the 3380. This is the right now is the more accuracy, the efficiency for PIs, the reference, but it's from the Caucasian. So, but we still think it can be the use right now. If possible, maybe in the 1 or 2 years later, we can propose the Taiwan the PIs for the breast cancer, and the PIs scores we are using the 56,000 SNP to combine with the PIs scoring and using the conditional logistic regression model to check. And very interesting, you can kind of maintain the plot. In the chromosome 6, we identify the very 6 significant those sites, and they are associated with some immune response and some from the pathologic effect. And the effect is very quite striking. So this is our identify the 6 maybe in the future the candidate as the PIS or the drug discovery candidate. And we can also see the PIS screening between the control and the case. They are quite different. And if you see the bar chart, we can divide the PIS with the quintile, and the top 20%. We can see the AYA percent. They are have the huge percent from the 50% increase to the 26%. So it means this reference for the PI screening is very sensitivity and for the AYA group. And also we can check the RC curve. This PIS, the reference group, we now have the significant explanation impact around the 0.68. Right now, you know, 0.68 is not very good, but we still can change the factor. But it's still right now is around the 0.68. If we later put more new candidate and more sample size, the number will be increased. And we also can see using the logistic regression for the 5 quintile, the odds ratio is around nearly the 2 is 1.3, 1.3, but 1.9 for odds ratio for increase the AYA, the breast cancer. And the last part I will talk, and the second part I will talk about the WES for the breast cancer. And the AYA, we are divided the 2 subgroups. First, we the very young people less than 40 years, around the 150 number person, and the other is 40 and 45. And this is a regular breast cancer onset age. And we can our ferritin ratio is focused on the 19 main DNA repair gene. And as you know, that this is a very famous ATM, BRCA1, BRCA2. So something there includes, but we want to see some new novel or new minor mutation, especially significant expression in the HR ethnic group. And this kind of DNA repair gene, we are focused on their pathogenetics. So we do our SNP identify, we have the 5 conditions. First is to look at their pathogenic, or they have the likely pathogenic, or have either one. And if they did not include these 3 groups, we can also, if we have the conflicting or uncertainty, but combined with the CATT greater than 20, as you know, the CATT is talk about the SNP low side and the evaluation region, and they can show their impact, the pathogenic impact of the specific gene, and the impact is ranked at the 1% top. So this is the cut point for our CATT 20. And right now, for the age less than 40 group, we identify the 4 belonging to this group. And these 4 we can see in the chromosome 17, there's chromosome 17 and the chromosome 11, and they also meet our criteria for that have the impact on the pathogenic for this specific gene. And for the age 40 to 45, we identify the 2 SNP, and they ranking as the likely pathogenicity and also the pathogenicity. And for the regular group, we also identify the 2 in the chromosome 11 and the chromosome 13, and they also show the pathogenic effect. So we combine these 3 groups, and I say we agree. This is the 3 groups. They have all the BRCA2. So in the NGS, the BRCA2 it cannot be ruled out. It's the first one, but for the age 24, we can see all the DNA damage repair gene broadcast series, they count about 3.3 and 4.3. But for this very young onset, the grouping, we still find the other SNP. They have almost the same impact with the BRCA. So this is very special for the Asia, for Taiwan people. They still find some very interesting SNP for the future research. So right now, for this one, we are proposed is a PRB2 and the Ready 51D. Might be the potential SNP because their mechanism is a protein primarily involved in the DNA repair and the break type, and the function is more pronounced for tumor cell. So this our later we will very detailedly to look at their mechanism stuff. And my final case is how to do the efficacy difference between the chemotherapy regimen in Asia AYA therapy. And this is our recent published paper. We look at the toxin and the anthracycline combination. Which one treatment regimen will be more effective to reduce the breast cancer? And we're using the National Health Insurance data and the Taiwan Cancer Research data set to link it with each other. And we can see sometimes I'm not MD, so if we are like my former boss, the Professor Yen, they have a very standard treatment protocol. If any patient be diagnosed as a breast cancer, first and majorly they will do some surgery and the subject, and then the patient will recommend you need to do some chemotherapy. And if you have the genotype checking data, they will propose you might be to combine some hormone therapy. Now hormone therapy maybe you have septin or hormone therapy with, but you have to check your ER, PR, and your HER2 SNP type. And then some patients will also suggestion with combine with the radiotherapy with the RT or CCRT something. This is a standard protocol, and this is a first stage treatment. And we want to talk about the anthracycline combined base and also the toxin base. And this is using the big data. So we talk is the observation for the treatment effect. And this is why we call the high technology reassessment. We can look at the treatment protocol based on the guideline is showing the expected efficacy or not. So this paper is checked with the extracycline base, and we call the AC, and the toxin base, how we call the AB toxin. And we check from the 11 to 2019, we have the around 5,000 AYA staging, birth staging 1 and 2. And this is our exclusion criteria. And the AYA staging 1 and 2, we have the patient received the chemotherapy or the hormone around the 1,600 the patient. And the AB regimen around the 700, and the TABCB regimen around the 800. And we're using the propensity score mentioned by age, molecular subtype, cancer pathology, age, staging, tumor grade, and the regimen therapy. And we divide two case group and the comparison group. And so you can see before we mention there are some difference around the age, around the AJCC pathology staging, and also the tumor grading. But after we do the Mahanomy distinct matching within the propensity score clipping, we can see the age and also the ACC pathology staging, they are very similar, did not show any significant. So they have the same base to do the compare. And after do the data analysis, the hazard ratio for AYA staging in 1 or 2 breast cancer patients, we specify like the molecular subtype in the 3 years follow-up. And the AB regimen compared with the TACB regimen, they're showing the significant effect to reduce. They are more better treatment efficacy for the this kind of early staging for the breast cancer and AYA people. And also, if we stratify the Lumina A and the B1, and also the Lumina B2 and the HER2 enrich and the best like it, this one also have the very good and similar, the better treatment effect for the hexing combined regimen treatment. And even the Lumina B2, HER2 enrich or the basal lax, they still have, but because the number is very small, so did not reach the statistical sim level, but we can also see the better trend for this treatment. And all this one the different time, we can see this the follow-up time year, they are very significant difference for these two regimen, the treatment. So in these 3 cases, I will talk about the breast cancer among the young individual in Taiwan or in Asian area. They're still rising, and the mortality is gradually increased. So this Taiwan need to look at and a very serious the check. This would amend need to do this, and also because the AYA is increased very faster than the non-AYA patient, so we needed to identify for the young onset the disease. Sometimes this kind of patient, the genetic component will play some very important role. So we need to identify some unique SNP among this group. So the second part, we are through the very standard protocol, we can identify the 2 very interesting similar sites. And the other, we are also find some case experience to prepare for the next time we will do the NGS, the HTR, and we can using the different treatment regimen and show how to do the treatment efficacy. And for this time, and our NHI will prepare our experience to do the next time, do NGS after we receive this mission. So I show this the current our experience and ask for your guide from the 3 study. Thank you.
Any question from the audience? Professor Chen Yuru.
Thank you very much for the very nice and important work. I think the early onset is very important, not only for breast cancer and also for other cancer types. So from your perspective, do you think that it's due to the aggressiveness, for example, early recurrence of this young patient, or is associated with the inherently more aggressive phenotype of the patient at the early stage?
I think the AYA right now is not found breast. We still found in the colorectal cancer. So in my perspective, we know the environmental and some lifestyle maybe country something, but I expect the genetic also play a very important role. So, but right now, because the sample number is quite small, so we are very difficult to identify very promising cerebral loci. So I think the multi-institute cooperate program is very important, especially in an academic clinic or any in the big hospital. We join the. So if we have the nerve and the sample size, we can do this one. Yeah. Okay.
Yeah. Go ahead.
Really nice talk. This may be a bit of a naive question. I was wondering, amongst the AY cohorts, what percentage of those are TNBCs, and is there any data on CDK4/6 inhibitors on these cohorts and any association studies with the genomics?
Oh, right now, as I mentioned for the professors, because AYA number is quite limited. So right now, this is the first. I cannot say the very big sample size, but this right now we can collect around the 300. Yeah, very difficult because for any even in breast or in current, they accounted maybe less than 5%. Yeah, in total it's 5%. So we need more institutes to cooperate. So our MBCT platform will be very good resources to collect this data. Yeah, yeah.
Professor Chiou.
Yeah, very nice work. But we have to think about the incidence. Even though in Taiwan, the young age breast cancer is increasing a lot, but still it's lower than the Western countries.
Yeah.
So if genetics plays a major role, then you will expect the risky SNP or protective SNP because it's still lower. So in other words, I would rather more favor the reproductive factor, especially environmental phytoestrogen, environmental hormone related, and the lifestyle.
Yeah, yeah. But I totally agree, the professor. I know the genetic effect cannot be more important than the environmental or lifestyle effect. But this is the relative impact. For the general the cancer, maybe the impact is quite low. But for the young onset, the impact is more important. But I know for PRS, we need to combine with lifestyle or any hormone level. If we can combine all these factors, we can predict more precisely. Even though you see my data is only the 0.68, because the pure PRS using the genetic, we cannot reach the 0.8 level. So we need to collect more environmental or more basic research study to increase. Okay, but AYA is very important because they have a very less percentage, but the mortality is quite high, and their progression is quite fast. So we cannot ignore this kind of the type in the cancer. Yeah.
Okay, thank you. Because time limited, so we have to close this section. And thanks to all the speakers, and also thanks to Professor Lines, the moderation. Thank you so much.